Professeur Roche,
Yes, hello.
vous m'écoutez?
Oui,
Okay, bonjour.
bonjour.
I will start our meeting now.
Okay,
We are honored to have Professor Julian Roche, Professor of Rheumatology. I will introduce him, but first we welcome you all for our review course. We'll start today we have very interesting lectures from around the globe as we are used to. And tomorrow we'll start our EGYSIR 15th annual meeting. We are happy to have you all with us, and we are honored and privileged by having Professor Julian Aroche. As an introduction, Professor Aroche is a professor in internal medicine at Pitié-Salpêtrière Hospital in Paris, France. It is the French Center of Reference for Histiocytosis. Since 2003, he focused on Erdheim-Chester disease, for which he gained a world-renowned experience. And world-renowned experience and other fields include in his interest other histiocytosis, as Langerhans cell histiocytosis, mixed histiocytosis combining Erdheim-Chester disease and Langerhans cell histiocytosis, also Rosé-Dorfman disease. He has interest as well in vasculitis, lupus, and the antiphospholipid syndrome. Over 20 years, he described clinical and radiological aspects of great importance and increased awareness of Erdheim-Chester disease. Reported interferon alpha as a first-line treatment. His team pioneered targeted therapies in histiocytosis in the year 2012. His center treated more than 250 patients with this line of targeted therapy. Added to this, or more and above, as I would say, when Professor Aroche accepted our invitation, we were honored and privileged. As I said, he has the other fame as King of Erdheim-Chester disease all over the globe. We are most welcome, Professor Aroche, and the stage is yours to start your presentation.
Okay. Thank you very much for this kind introduction, and I hope I will not disappoint you. So I don't know. Do you see my screen?
Yes, clear.
Okay. So again, thank you very much, and I will try not to be too much over time. And so first of all, so histiocytosis are disorders characterized by inflammation and accumulation of cells which are derived from the monocyte and macrophage lineage, which results in tissue damage. And here you have many examples of histiocytic cells which often occur in infectiology, such as leprosy, tuberculosis. You have here the cells of MAS and the two-tone glial cells with multiple nuclei here, which is the cells that you see most often in Erdheim-Chester disease, but also in juvenile xanthogranuloma. So until relatively recently, it was believed that histiocytes, which are dendritic cells and tissue macrophages, originated from circulating monocytes or other circulating myeloid progenitors, which themselves derived from bone marrow progenitor. And that was what was thought. But in reality, at the basal state, the majority of those tissue histiocytes come from embryonic hematopoiesis, and in particular from the yolk sac. And then they colonize different tissues and acquire the capacity of self-renewal. And in the contrary, in inflammatory state, when you have an aggression, an infection, in order to help resident histiocytes, monocytes, and myeloid progenitor have the capacity to differentiate into macrophages and dendritic cells to play their inflammatory role. But regarding histiocytosis, the question arose of the origin of the mutated histiocytes, and it was clear that histiocytosis come from mutated BRAF gene, which are in the stem cell and myeloid progenitors. So if you want to remain simple, macrophages are scavenger cells, and dendritic cells are presenting cells. And most importantly, when you face an histiocytic disorder such as Langerhans cell histiocytosis, which I will speak further in this in my talk. Here you have an example of a baby with a crusty eruption from the scalp, and so he had a biopsy. Here you have the HAE coloration. And when you do a CD1A, which is a very strong marker from LCH, you can see it's positive here, but with a greater magnification, you can see there is a magnificent scabies, and this is an infection. So it is really important to have pathologists which are trained and going back to the clinics and asking. There is this strong interaction, at least in France, between the pathologist and the clinician. And so here are the main mimics of LCH, but it's also valid for other histiocytosis. And each year, so you have many infection, you have sarcoidosis, glioma, many other mimics here. But there is also one you should be very aware, which is Hodgkin lymphoma. Each year, in the center of reference, we have one or two Hodgkin, and here it's over 15 years, 600 bone biopsy read by Jean-François Emile, and you can see that 7 or 8 are Hodgkin disease, and one of them even died of this disease due to a late diagnosis. So you should really think doing PAX5 and CD13. So the major breakthrough in the field of histiocytosis was by the team of Barrett-Rollins in Boston, 2010, this publication in Blood with recurrent BRAF mutation in LCH. This was just no correlation with clinic. It was just some stained biopsy. And in the years after, we were able to, with other teams, to confirm this. And so this is a very important pathway, the RAS-ERK pathway between, so you can see here the layer, and this is RAF with the BRAF V600E mutation, which is a proto-oncogene, and you can see after MEK-ERK, and then there is a signal that enters the nuclei with proliferation and survival. And this pathway gets constitutionally activated. And it's about 50% of metastatic melanoma. You have a little bit of colon cancer, thyroid cancer as well, 100% of hairy cell leukemia. And depending on the techniques, you can have half or 2/3 of patients with LCH and ECD, and you almost never have Rosai-Dorfman, which have a BRAF mutation. And so this was the basic of the 2016 WHO classification under the influence of Jean-François Emile. And now you don't speak of non-LCH and LCH, you speak of L group histiocytosis with LCH, ECD, the mixed mainly. Then you have the C group, which is only skin, various skin I will talk about. Rosai-Dorfman, the malignant histiocytosis, and the H group, which probably shouldn't be in this classification because it's not per se involvement of the histiocyte, but it's more like lymphocytes which are affected in this classification. So the most frequent involvement or histiocytosis is GXG, which is mostly sometimes just a pimple. You have here on this example. It's mostly skin. Young children, it's one case out of 1 million. There's a slight male preponderance, and about 10 years ago it was found that there is already a pathologic ERK activation, and you have also some very strong association with GMML, which can be found especially when you have NF1 mutation. And again, you can see here that this is a two-tone giant cell. You can see this in ECD and in GXG. You have no difference in histology. So this is why it's important to get back to the clinics. So this is GXG is mostly skin. You have in 5-10% extracutaneous involvement with sometimes systemic organ compression, such as liver, spleen, CNS. And the basic of the treatment was before based on LCH with vinblastine, 2-CDA, Ara-C. But in the past 5-10 years, there has been many cases where BRAF inhibitor were given, especially, of course, when BRAF was present. And here you have the list of the molecular genes that are affected in this disease. So skin is not only, it can be just an issue, but you can see that in this patient here on the upper right, you can see he had only skin involvement, but you do understand that this patient wants to be treated, and especially with targeted therapy, which can be given that usually we don't give just for skin unless there is a very aesthetic, obvious issue. So many skin involvement, many doctors that gave their name for this description, and here are listed. You can go back to the Lancet paper, which gives many examples. Just the multi-centric reticulohistiocytosis, which is very rare with a rheumatologic aspect. And then you have also xanthoma disseminatum with this multiple skin lesions here. So again, many descriptions. Now I will switch to malignant histiocytosis because there is some new data in the past 5 years. So before, if you put many pathologists around the same histology, they would fight because there was many description: histiocytic sarcoma, Langerhans cell sarcoma, indeterminate dendritic cell tumor, but it was all referring to the same malignant histiocytosis with a very high Ki-67. So we decided with Jean-François Emile and other pathologists to describe just a single entity, especially with the molecular data. So there was a large retrospective series, but from I think 5 or 10 years ago, with only 43 patients. And in the center, the French center, the French group, we went back to the archives, back to the early 2000, and we were able to analyze more than 120 cases with possible or confirmed MH. It was confirmed in 61 cases. And so you have here an histology, typical histology, which I would I will not be able to comment on that, but sometimes you have to be aware that it's difficult to confirm malignant histiocytosis, and sometimes you have histiocyte-rich malignant tumor, which are here on the right. So we had 140 patients with confirmed diagnosis, median age of 62, but you have also 10% of kids and very young children, slight male preponderance, and you have 1/3 that are localized or disseminated. And here you have all the involvement that were seen in this series. The primary malignant histiocytosis was seen in 2/3 of the patients, and you can see for the secondary the variety of hematologic neoplasm with all kinds of lymphoma and CMML, MDS, and leukemia as well. So if we go back to the subtypes, you can see here this has no real interest now, because we do speak only of malignant histiocytosis. And you can see the variety of markers that are seen here, mostly CD68, which is a pan-macrophagic marker, PU1, CSF1R receptor, which is an important marker for the development of monocytes and macrophage, and so on. So many mutations has been found: KRAS, NRAS, BRAF, or MAP2K1. And in the contrary to Erdem-Chester and LCH, you can see that you can have multiple mutations in the same patients in the pathway. So there is also one striking figure is PTPN1, PTPN11, which is only seen in primary MH. And this is a marker that is also seen in Bouvier-Bernois sarcoma, which is a sarcoma of the dog. So it's a very bad prognosis with patients who mostly die after a couple of years, especially when they have CNS or spleen involvement. And you can also see that I told you that some of the patients, yeah, I'm sorry. So in terms of treatment, there's a slide that is missing here. The first strategy were to give polychemotherapy and especially totem or ICE regimen. But now what we tend to do is discuss in a tumor board. And when you have mutations of the MAP kinase pathway, we give MEK inhibitor or MEK inhibitor plus BRAF inhibitor. And then if it doesn't work, we can switch to polychemotherapy. So we try to give one and the other. And we have sometimes good results with targeted therapy. And the other possibility, as I told you, is to give immunotherapy. And we have this case of patient who had a dramatic response to nivolumab and who was alive after a couple of years, which is a very good result. So the next disease I want to talk to you, and it's one of the diseases I got involved in this field, is Erdheim-Chester disease. Jacob Erdheim was a pathologist in Vienna, and he died just before the beginning of World War II, and he was involved in the description of many diseases. He was actually involved in the treatment of Sigmund Freud, at least Sigmund Freud cancer. And William Chester was a pathologist from the US. He began as a pathologist, ended as a cardiologist, and they described the two first patients in this very iconic publication from 1930. It was obviously autopsic finding, and you can find all the description of what I'm going to tell you just after. So very difficult to know the number of cases, probably over 3,000 if you mix the publication, the registry, and the iconic image you have to remember is the long bone uptake. Before it was a bone CT scan, and now it's replaced by a head-to-toe TEP scanner with a long-term, the lower limb and the upper limb hyperfixation, rather sparing the other aspect, the other location of the body. Then you have also the hairy kidney infiltration, which can be quite massive. And when you examine this patient at the beginning, you had the feeling you were palpating a large spleen, but it was in fact the kidney. And it's not a view of the radiologist as the patient had lost one kidney here after, and you can see the very important fibrosis. So there are a couple of differential diagnoses. First of all, you can have myeloproliferative or myelodysplasic syndrome sometimes, but there is also one patient that was seen in our department, which in fact has a Schnitzer syndrome, which is a rare autoinflammatory syndrome with M gammopathy and also some skin lesions, and it's a disease that is also responsive to anakinra, which is one of the drugs of Erdheim-Chester disease. But apart from that, it's very there are very rare differential diagnosis with when you have a long bone uptake like that. So the histology is absolutely mandatory. If you have the choice, you have to pick up a xanthelasma, which is usually very rich in histiocytes, and it's possible to do molecular data. Molecular studies. You have to avoid, if possible, bone, because you have a problem with decalcification, which is a problem for molecular study. And the peri-kidney is also the preferred site, because even if you have thrombopenia or anticoagulants, you can do a peri-renal biopsy, as you don't do a renal biopsy, but it's a peri-renal. The Ki67 is usually very low, so it's not a cancer per se, even if you have some cancer mutation such as BRAF. You need to have a CD68 or even better CD163 staining, and the CD1A is negative, which is CD1A is what you find in LCH. So very few data from the natural history. So some patients may have a very mild disease with a little CRP and bone pain. The sex ratio is usually 3 men for 1 woman, and it's usually a disease of 50, 60 years, but you have some patients which are infant. You have now series of 20, 25 ECD in the kid, and you have over 80 years old. It's usually inflammatory disease, even if it's a little bit less than what you see in Rosai-Dorfman disease. First symptom is extremely variable, and diabetes insipidus can sometimes precede the disease up to 20, 30 years, and usually the patients have what they call diabetes insipidus of unknown origin. So this is what you can see when you have the chance of having a plain plain radiographics, and you can see here that there is you don't see the medullary cavity anymore. You have osteosclerosis of the diaphysis and metaphysis, and even also the epiphysis. And you don't there is no parallelism between the uptake, which is present in almost more than 90% of cases, and only 40 to 50% of patients have bone pain, sometimes very important, needing some morphinics and NSAID drugs. So this is a true disease for internists. As you can see, that most patients have extra-rheumatologic involvement, and you can see here that it's mainly xanthelasma. I will list some of the most striking features, which are in red, and in particular the pseudoatrial mass. The 3 main pathologic neurologic involvement is tumoral infiltration with the meningeal masses, which can be seen obviously in granulomatous with polyangiitis, IgG4 disease, but also ECD here with the retroorbital infiltration. The most devastating involvement is the pseudodegenerative infiltration, which is really, it's not infiltration, it's atrophy of the cerebellum, which can be also seen in LCH and in mixed histiocytosis, and a little bit less rare, less frequent, sorry, by analogy with the periaortic sheathing. You can see sheathing around the vertebral and the carotid artery, and usually there are not that much of strokes. This is also a patient I didn't know back from 50 years ago almost, and you can see a major exophthalmos here with chemosis and some problem with the optic nerve, and you can see one of the first CT scan, and you understand why there is exophthalmos here, and it's one of the last indication of surgical debulking and also steroids. Steroids are not a good drug in Erdem-Chester disease. So what I was involved first was the cardiovascular aspect of the disease, and a few years ago, we analyzed retrospectively 200 patients with mainly MRI, a few CT scans, and we got back to clinics, and we were able to describe the atrial infiltration, pericardial involvement. You can see that a mode of entry in the disease is cardiac tamponade, sometimes deadly. You have to think of Erdem-Chester disease, and there is a very strong association between BRAF with an odds ratio over 7 and cardiac infiltration. So these are examples of atrial mass with, you can see the sheathing around the right coronary artery. This is a CT scan with gating, and you can see that sometimes you have masses around the left atrium, and you can see here the heart has some problem because you have many masses around, in particular, the left coronary artery. So you have also a very frequent coronary artery disease and myocardial infarction. This is not specific here of ECD, because you can see that in GCA, in relapsing polychondritis, but when you have the schissing around all the aorta here, it's called coated aorta. And a good sign of thinking that this is due to Erdheim-Chester disease is that you have a regular circumferential schissing around the aorta without any sparing of the posterior aortic wall here. This is usually spared when you have retroperitoneal fibrosis. And if you have a doubt, you look around the kidney where there is a perirenal infiltration. So it can affect many vessels. You have overall little clinical consequences, not that much stroke, a few mesenteric angina, but you have to be very cautious when you have an ECD patient with high blood pressure. You definitely have to look for renal hypertension, as you can put stent, and it's a good indication for renal stenting. Back 15 years ago, we started doing some research on chemokine, and as it is an inflammatory condition, and we're able to identify a cytokine signature which was more like a Th1 response, with more IL-12, more interferon alpha, and more MCP1. And we thought at that time that this is a cytokine that attracts monocytes in the tissue. But here, if you we summarize the pathophysiology of the disease, and getting back to what I told you in the beginning, so BRAF, the mutation gets into immature progenitor in the stem cells, and then so the monocyte gets in the circulation and bloodstream, and then they get back to the tissue with a migration of the monocytes and differentiation into foamy histiocyte, and that's there that you have the inflammatory response with a lot of cytokines and chemokines receptors, and then you activate the senescence program. And so here are the mutations you can find: CSF1R, some fusions and on the outer layers, and then the mutation you can target with BRAF inhibitor, mainly vemurafenib and dabrafenib, and for the MEK inhibitor, it's cobimetinib and trametinib. You have also in 10-15% patients with PIK3CA mutations that can be targeted with mTOR inhibitor, with mainly sirolimus. And also, so some of the patients can be treated with anakinra, and there are also a couple observations with tocilizumab. So one of the first patients that was treated in our department was a very multisystemic patient, a woman who had all these pericardial effusions, right atrial tumor. It was obviously before the BRAF era, and she got a sudden stroke, and you can see that there was the basilar trunk was obstructed, and after very high doses of alpha interferon, we were able to treat this sheathing here. But the problem with interferon alpha, which is one of the last indication on the long term, which is Erdheim-Chester disease, you know that C. hepatitis is not anymore treated with that. You can treat some myeloproliferative disease a little bit with interferon alpha. There is a problem of tolerance. And 15 years ago, we were able to show, even if it's two groups were more in favor of interferon alpha, it was the first demonstration that giving interferon alpha is good for survival. And so here are the second line treatment, mainly anakinra. So there is a very strong association when you look at BRAF mutated versus wild type. You can see that cardiac involvement is very much associated with BRAF, especially when you have the right atrial masses, and also xanthelasma and cerebral involvement. So the history of BRAF inhibitors started back in 2012 when it was first licensed for melanoma, and we gave to the 3 first patients which were refractory to everything. And so the story started like that. Then it were 8 patients, and the nuclear medicine called us saying that they had not seen any metabolic responses such as this one after 1 month in the same patient. And these are after the 8 first patients with some of the SUV that were as high as the one you saw in cancer. And all patients responded not only metabolically, but also with masses in the heart and around the aorta that responded very well. For the brain, when you have the pseudodegenerative aspect of the disease, the hypersignal, they go away, but usually patients that are ataxic or in wheelchair, they have problem to get better. So over time, BRAF inhibition, you can see worldwide, many patients, either in the United States with Eli Diamond, some cases of patients who have severe involvement with CNS that were about to die and who could get out of the ICU and back home. And a couple years ago, we had more than 200 patients with ECD. And worldwide, it's mainly ECD mixed patients, not much of adult LCH, but a lot of children LCH that were treated with BRAF inhibitor. And then the MEK inhibitor arrived on the market a couple years after, and Eli Diamond in the US just gave this drug in a small trial with, you can see here, 12 ECD, 2 LCH, 2 Rosai-Dorfman, and 2 mixed patients. And it's just a clinical paper that was published as a letter in Nature, which is a very good paper. And this is the 2 pivotal studies in the US. You can see that the vemurafenib was given for BRAF inhibitor, for BRAF patients in the US, and it was approved in 2017, and MEK inhibitor were approved 3 years after. So it's really paved the way for the treatment worldwide. The only problem is outside of the US, it's off-license drugs, and sometimes patients have a problem to get access to these drugs. And here you have also we did a double-blind placebo-control study following Eli Diamond study, and this is all patients had 9 months of the MEK inhibitor cobimetinib, and we have some very good results that we should publish in the next couple of months. Again, you can target all these mutations, as I told you, but it's not anecdotic, it's not paracetamol, because here are the side effects we have been demonstrating in 2017. You can see that most of the BRAF inhibition, you have to protect efficaciously against the sun, which is one of the problems. You have many cancers, skin cancer, you have QT prolongation, and you have over time, you can have a paradoxical activation of the pathway and induce KRAS or NRAS pancreatic cancer, and also myelodysplasic syndrome. For the MEK inhibitor, it's usually a very severe acne where you have to give doxycycline and also some gut issue and some rhabdomyolysis. So over time, we were able also to show that when you give BRAF inhibitor, and if you stop after 6 months, most of the patients are going to relapse. And so now we don't stop anymore BRAF inhibitor. We just taper and give like 1 vemurafenib a day, and waiting for seeing what we're going to do afterwards. In ECD, you can see this was 5, 6, 7 years ago. There is no difference in the survival of patients, whether you are BRAF mutated or wild type. And you can see here that 5, 6 years ago, the median survival of patients were 12 or 13 years, which is much better than what it was originally. If I say just a word on LCH now, it's a disease mainly of the children. You can see all the involvement. There can be a particular focus on pulmonary involvement, which is usually very much linked to the tobacco. And there are 2 very severe involvement of the patients, which are sclerosing cholangitis and the neurodegenerative aspect of the disease, which are usually linked to BRAF. So Jean Donadieu in France, which is a pediatrician, shown that for the children, BRAF mutation is usually of worse prognosis, and it's associated with resistance to first line treatment, which is vinblastine and steroid. And now Jean Donadieu and the European group, and also some other world groups, have treated more than 250 LCH patients, and with very good results, except for the neurodegenerative lesions. Now, a few words on Rosai-Dorfman disease, which is less a disease than a syndrome. It was first described by this pathologist, French Detombe, and you can see he was an infectiologist in the beginning, and he described the disease in this 1965 French journal, and then it was described with exactly the same by Dorfman and Rosai, with 34 additional cases. And this is from the Detombe paper. It's usually massive, bulky lymph nodes with a general state which is conserved. And you can see emperipilosis, which is lymphocytes within the macrophages. And usually you have very high CRP. And this is just, you don't treat patients with that unless you have compression of other organs. Virtually every organ can be affected with Rosai-Dorfman disease. And it's more severe when you have CNS and also autoimmune disease with systemic lupus, hepatitis, and hemolytic anemia. There is also overlap with IgG4 and also some genetic SLC29A3 Rosai-Dorfman, which is a particular form of the disease with this mutation, and it's autosomic recessive with short stature, with hypoacusia, heart abnormality. It's a totally different form of the disease, which you can treat either by tocilizumab or by MEK inhibitor. There is no consensus for the treatment of Rosai-Dorfman disease. Sometimes it's self-limited and you just do a wait-and-see strategy. And usually you treat when there are severe diseases and involvement. And usually we choose first-line steroid and methotrexate. Ritux is usually given when you have autoimmunity. And you can see here that BRAF is never mutated. And most of the time you do not know where the mutations are, and even if you don't know where the mutations are, and if you have as well a KRAS mutation, this is an example of a cobimetinib patient with Rosai-Dorfman disease. There is a continuum between all histiocytosis. You can see here that BRAF is explaining why you have LCH and ECD. This is more recent with 69 patients with this association. And we also show with a collaboration with the US group that 10% of the patients have overt myeloid neoplasm, which is mainly CMML. And so the BRAF mutation can be seen in the CD64 bone marrow cells, as well as TET2, SRSS2, and JAK2. So it really comes from the myeloid compartment. And so why is that? You can imagine that TET2, which is an epigenetic regulator, which arise in the bone marrow progenitor, then it can it can help acquiring additional mutation. If you acquire JAK2, then you go either via MPN or MDS syndrome, and then if you get BRAF, you get towards Langerhans or Erdheim-Chester disease. And you saw this publication in the New England back in 2017, where TET2 mouse had an accelerated atherosclerosis. And so we looked at clonal hematopoiesis in Erdheim-Chester disease, and there is more of these CHIP mutations, which are increased by 40%. and you can see that it's the same mutation, TET2, I6LN, DNMT3A, as the mutation you see in CMML. And when you do a clustering, it's interesting to see that BRAF and TET2 are in the same cluster, BRAF being linked to the heart involvement and TET2 as well, as I showed you just before. Again, this continuum can be seen, Rosai-Dorfman and ECD, which are mainly driven by MAP2K1 mutation. Here, 13 patients with testis involvement, mainly men, and MAP2K1 mutation. And these patients have mainly a phenotype of Erdheim-Chester disease. So for the clustering, we are doing now clustering, a wall clustering in Erdheim-Chester disease with above 600 patients, mainly from France and Italy. And we tried to do this kind of unbiased clustering, and we were able to delineate 3 main clusters: the widespread cluster, the limited cluster, and the MAP2K1 cluster. And so here you can see that half of the patients had the widespread cluster here, which is all what is red, with most of the involvement I told you on Erdheim-Chester disease, a long bone, heart, CNS, vessels, and they are all mutated BRAF. And here you have...
لا انا هبدأ لك بالامير الثاني، سيبها دلوقتي.
What? So here you have the MAP2K1 mutation here, which is on the right, and it's linked with Erdheim-Chester and Rosai-Dorfman, and limited to one organ. And here is a swimmer's plot, the spider's plot, where you can see it in another way of describing those men cluster. And you can see the prognosis is worse when you have a widespread disease linked to BRAF. It's worse than when you have the 2 other clusters. What is very interesting is that the MAP2K1 mutation, you never see neurodegeneration. So other newer aspect is anaplastic leukemia, kinase positive histiocytosis, which is quite important to look over. It's you have 40 or more patients now, kids and adults, some with neurologic involvement. And what is very important is that you can now also you have ALK inhibitor targeted therapy, and you can see here impressive responses with lorlatinib or crizotinib after a couple of weeks of treatment. If you have an histiocytosis that is not going well, you can do a phospho-ERK immunostaining, and even if you don't know where the mutation is, this is sufficient to give a MEK inhibitor and then to see what's going to happen, because it can save a life. Other mutations, CSF1R, as I told you before, and it's probably more seen in Rosai-Dorfman disease, and it's an important receptor for macrophages and monocytes. And in the US, they have access to pexidartinib, and they treated patients with a couple of ECD patients, and we are unable to have access to this drug in Europe, unfortunately. Here are the main mutations found in LCH and in ECD, and you can see that over time, on the pie charts, the number of mutations and the percentage of histiocytosis where you do not know where the mutation is getting smaller and smaller. So very impressive also publication from the group of Frederick Geisman in New York. He was able to introduce BRAF in utero, and then the mouse, so as I told you, because most of the mutations come from the yolk sac, and when the mouse were born, he gave a BRAF inhibitor, and you can see that the one with the black arrow here has a cerebellar syndrome, and this one was not able to get the BRAF inhibitor. So it's a little bit provocative. It means that at least in mouse, a patient that have histiocytosis with a BRAF mutation should probably get access to the BRAF inhibition. So take-home messages: LCH and ECD are often associated and are now become they belong to the L group from the revised classification. It's clearly a myeloid inflammatory neoplasm. It's important to have a systematic review of the patients with appropriate molecular study. And in France, Europe, and in the world, he looks at every samples. Jean-François Emile does that for free. BRAF mutation is associated with a cardiac and neurologic phenotype in ECD. BRAF has more influence on the survival of patients with LCH. Maybe it's going to be the case with ECD. And interferon alpha has still a place for mild ECD because you cannot have access everywhere to targeted therapy. And we do think we only have to treat patients with heart and CNS patients for ECD because it has frequent side effect and it's costly. In France and in Europe, it's only off-label and there is no resistance to date after more than 10 years of use of these drugs. We do not know if we have to use combo therapy in ECD and mixed histiocytosis. In melanoma, when you combine BRAF and MEK inhibitor, you have better efficacy and less toxicity. It doesn't seem to be the case in ECD. New approaches by the colleagues from Italy is to have vacancies of treatment when you have patients who are in complete remission. You put them off the drug for 3 to 6 months and it saves money and they can go to the sun and it's about the same result. And now you have in the US the PAN-ERK and PAN-RAF agents, which we didn't have access. And we have still this international clustering with almost 1,000 patients. And this has all the colleagues. I work in France, mainly Jean-François Emile as a pathologist, and also the friends and colleague from Memorial Sloan Kettering in the US, and the ECD Global Alliance, which does a lot for the patients worldwide. Thank you very much, and sorry if I was a bit long.
Thank you very much, Professor Arosh. That was very surgically presented as well as panoramic. I think we are short of time, so one just reserve the right to pose one question. Dr. Ghanima, he wants to ask about a case that he managed to take care of for over 15 years. Have to be very short.
Thanks, Doctor, for interesting and concise lecture. Mahmoud Ghanima, lecturer of internal medicine, Cairo University. I'd like to take your opinion about a case of Erdheim-Chester disease. A 57-year-old male patient diagnosed based upon bone biopsy. He was maintained on everolimus 1.5 milligram per day. He was initially controlled, but recently he has severe joint pain and bony pain with marked increase in inflammatory markers, EGYSIR and the CRP. I'd like to take your opinion. And the next other case, also patient 52-year diabetic, diagnosed more than 10 years, depending on bone biopsy also. Patient was maintained good regarding soft tissue, but recently bone became very soft and rarefied. So I need your great opinion. Thanks.
So
may I add something? The second patient has been diagnosed for over 15 years.
Yes.
And earlier he received other medications, but he responded nicely in the soft tissues with everolimus, and now it's 15 years. There are no soft tissue lesions at all, but the bone is still hard to respond.
Okay. Do you have molecular status for both patients, or you were not able to?
Unfortunately, not available now.
And because you have no access to the biopsy anymore, or the blocks were you have not anymore. You don't have any more access to the biopsy.
No, biopsy we can take. But genetic test are not available. But biopsy we can take a new biopsy.
Yeah, maybe I either have access to the old biopsy and send it. I will give you the address by mail of Jean-François Emile, and again he can try to do a digital PCR and try to amplify the DNA if the quality is enough good. If you have anything to biopsy apart from bone, it's probably better. If you don't have anything else than bones and do the bone biopsy and send some slides and blocks to Jean-François Emile, and he can do that for free and do the genetic testing. Then I would, for the first patient, if he responded well to sirolimus or everolimus, you could, if he has articular involvement with CRP elevated, maybe you could try giving anakinra on add-on, or when you have the molecular testing, and if you have access to the drug, you could perhaps discuss a BRAF inhibitor or a MEK inhibitor. I don't know. I don't know if in Egypt you can get these drugs, or if it's too difficult. I think it's possible to get these drugs. I would say, but I'm not working there.
May I comment, Dr. Arosh? I think we have the paraffin blocks, and we are very grateful for this invitation to share the case with you for free. That's very generous of you.
Yeah.
And
Just
as
the only thing you should do is have a safe way of sending. The only cost would be to do a FedEx or whatever Chronopost, just to be sure that the slides and the paraffin blocks won't get lost when they get to Paris. But this is the only cost it will be. And the second patient, I don't really remember what it was. It was also under everolimus, right?
yes, everolimus, but it has been for 4 months, not more.
Okay. And there was a soft tissue and it went away.
No, it all occurred in the bone, in
Okay.
the lower leg and the ankle.
Okay. So I would also try to, you can send the 2 biopsy in the same package, I would say, and see if you have some mutation that can be targeted, and then I mean, if the patients, I would say, don't respond well or finish by resisting to the drug, which is everolimus, I would consider maybe targeted therapy, even a low dose targeted therapy, because they don't seem to have very severe involvement. It's painful, but it's not like.
Vimurafin is available in the National Cancer Institutes, and we can do that with them if they accept. So thank you.
And also if they have BRAF mutation, obviously, because this is the only limitation. I mean, BRAF inhibitor is only given when you have a BRAF mutation.
Okay, thank you very much, Professor Arosh, for that very
and I'll send
enlightening lecture.
Okay, and I will send you by mail the address of Jean-François Emile, and so we can keep on like that. Okay.
Thank you very much.
Thank you very much for the invitation.
Thank you for responding nicely with this elegant presentation.
Thank you very much. Bye bye.
Bye bye. À bientôt.
À bientôt. Au revoir.
Now we have Professor Vanessa Hafiz. We are sorry to have encroached on your time.
Not at all. It was a pleasure to have Professor Arosh.
Thank you very much. We are privileged also to have Professor Vanessa Hafiz, Professor of Dermatology in the Department of Dermatology at Cairo University. She is a member of the Qasr Al-Aini Psoriasis Unit, her clinic's Cosmetology Clinic, and Derma Laser Clinic. She combines scientific expertise with a patient-centered approach to advanced derma care. Thank you for accepting our invitation, Professor Hafiz. And before we start, I just ask you if you are able to turn off your mobile phones, or at least put them on the airplane mode, please. The stage is yours, Professor.
Thank you very much, Professor Ghaffar. It's really a pleasure for me to be here today among my colleagues. Thank you for the conference committee and for the attendees. I have to thank also the chief resident, Dr. Aya Rafat, who took the lead of those lovely residents at our department to collect like 300 plus pictures of our patient database to choose the best to present to you today. I also used educational websites and pictures from published articles. So let's start. I think we all agree that the cooperation between both departments is for the best outcome of our patients, but I also enjoy very much this cooperation in my daily practice, and I learn a lot from my discussions with my colleague rheumatologists. What's really specific about the skin and really interesting and amazing is that it's usually the earliest presentation of the autoimmune connective disease, connective tissue disease. And there are so many skin signs that are specific to certain diseases and point to the diagnosis. Of course, many times the differential diagnosis needs expertise, and that's why we are here. And there's also a predictive value to systemic comorbidities and also predictive value to some therapies to be adjusted according to the manifestations of complications. So this is my first part and the longest part of the lecture about the cutaneous manifestations of classic rheumatic diseases. It's quite a long ride, so please bear it with me and have fun. Let's start with lupus erythematosus. The spectrum is either systemic manifestations or cutaneous manifestations. There is also drug-induced lupus, so that we do not forget to take a thorough drug history from our patients. Many times, lupus-like syndromes are induced by some drugs. It's rare to see cutaneous manifestations in those patients, although in biologic-induced, drug-induced lupus, we can see some photosensitivity. The cutaneous lupus erythematosus has been classified classically into specific cutaneous lesions and non-specific ones. The non-specific are really important because they denote systemic affection and comorbidities. The specific cutaneous lesions are divided into acute, subacute, and chronic, and some other rare manifestations like bullous lupus or Rowell syndrome. It's important to remember that some of those cutaneous patterns are signature patterns that repeat themselves with each flare. This is how we see the sites of predilection of each type of the specific lesions of lupus. We can notice that the photosensitive skin is common among all types. However, in the subacute cutaneous lupus, it favors the upper trunk, while in the like we see here, like, I'm not sure this is a good pointer, maybe. I can do with, yeah, it's too big. Like this? Okay, thank you. Okay. By definition, chilblain lupus favors the extremities and the cold parts of the body, while lupus paniculitis favors more the proximal sites that are fatty and pendulant. Discoid lupus and tumid lupus favor the head and neck and the upper chest. And now we start with acute cutaneous lupus with the characteristic malar rash and butterfly rash. This is a teaching picture from DermNet that shows striking erythema that is strikingly sparing the nasolabial fold, as you can see here and here. It's not easy to use the pointer. It might be flat or raised, and it is photosensitive. But we have to recognize more subtle presentations, like in our patient from Qasr al-Aini. Also in this patient, you can see that the nasolabial folds are spared. In darker skin types, you can see that the color is more towards the violaceous or the brownish color, again sparing the nasolabial fold. In continuity with the manifestations of acute cutaneous LE, those are non-specific findings, but I like to present them now. This is the picture of generalized maculopapular rash that might involve any part of the body. and it flares in a signature pattern with each flare. Those are the erythematous involvement of the hand, sparing the knuckles, and that's why the name is reverse Gottron in reference to the reverse of the Gottron sign in the dermatomyositis that involves specifically in the knuckles. This is typically non-scarring lesions. It might evolve in the acute cases into rarely acute severe flare that simulates toxic epidermal necrolysis that is induced by drugs. We can see the mottling in the middle picture. We can see large areas of mottling with central pallor and impending sloughing, and then in the both right and left pictures you can see large sheets of epidermal sloughing simulating a burn patient with even more worse prognosis because of the underlying immune disturbance. And the mortality risk, although it is less high than the drug-induced 10, it is still a risk. Here you can see our patient. Don't forget that it involves also the oral mucosa. You can see the large sloughing sheets of epidermis and the large area in the back with mottled skin, with impending sloughing. Other non-specific skin signs, we recognize the lupus hair and the mucocutaneous ulcers, one of the 11 diagnostic criteria in the EGYSIR definition of lupus. Those non-specific findings are very important because they point to comorbidities due to vascular complications. It's either vasculopathic manifestations or vasculitis. We can see palmar erythema, Raynaud's, periangual telangiectasia. We can see livido reticularis. Again, this is a vasculopathic manifestation. It's a fixed network of erythema that becomes later on pigmented. We can see atrophie blanche, which is a scarring most commonly on the lower leg over the malleolus, like this one too, and denotes vasculopathy. Degus-like or malignant atrophic papulosis is recognized by the primary lesion of erythematous papules with central scarring described in the literature as porcelain white scarring. However, this is not always the case in our pigmented skin. Always remember in those patients to screen for antiphospholipid antibody syndrome. Again, another patient with more subtle presentation of Degus-like. This is an etoderma. You can see wrinkling, spots of wrinkling of the skin due to loss of the dermis component, and this is a vasculopathic sign. Subungual splinter hemorrhage. Again, investigate for systemic complications, most importantly, antiphospholipid antibody syndrome. Now we go to vasculitis, not just vasculopathy. Leukocytoclastic vasculitis primary lesion is the palpable purpura. And the other type of vasculitis commonly seen is urticarial vasculitis. How can we diagnose it? So this is leukocytoclastic and this is urticarial vasculitis. Well, the primary lesion and the diagnostic index for urticarial vasculitis is non-evanescent wheals, because in the allergic urticaria, you see wheals that change the place every few hours. This is not the case in urticarial vasculitis. This wheal is here for several days. And when you take a biopsy, it is diagnostic. When it clears, it leaves post-inflammatory hyperpigmentation, unlike the allergic urticaria. Now we go to subacute cutaneous lupus manifestations. It either manifests as annular, like this close-up view, or papulosquamous. This is a close-up view, and this is a wider view. Both are non-scarring. And the neonatal lupus happens when a child is born to a mother with positive anti-Ro and anti-La antibodies. It is non-scarring, but the risk is lifelong heart block. Other manifestations are the chronic cutaneous lupus, of which the most common is discoid lupus. How do you recognize it in the early phase? Because this is a scarring disease. You want to treat it in the early phase because unless you treat it early, it will turn into disfigurement. You recognize it by the erythematous or violaceous plaque over the head and neck, most commonly. And you can see the scaling that is adherent, and you see follicular plugging. It might involve large surface areas like this. And the best to diagnose is first the dermoscopy. It's really diagnostic. And if there is no dermoscopy available, it's biopsy. It affects commonly the inner ear. And when it affects the lips, it gives rise to atrophic discoid lupus. And this carries the risk of squamous cell carcinoma after several years. In the scalp, the problem is the scarring alopecia, and that might be really disfiguring, like you can see. That's why you really need to diagnose it at this early phase. This is a burning plaque. The patient had several plaques like this in her scalp, and you can see the adherent scales, the follicular prominence, and by dermoscopy and biopsy, this was confirmed. So please, whenever your patient presents with burning, red scaly patch in the scalp, please think about discoid lupus. At this phase, if you treat it properly, you will avoid the scarring alopecia. It might extend to lower areas than the head and neck and take widespread distribution. Also, it might be hypertrophic, commonly over the shins of tibia. This is hypertrophic discoid lupus. And this is the dermoscopic finding showing the black dots, which is the follicular prominence. And this is a close-up view. Another type of chronic cutaneous lupus is lupus panniculitis. It involves all the pendulant and fatty areas of the body, and the diagnosis is through, like you see, there is a marking in the middle picture for incisional, deep incisional surgical biopsy. It is at the early presentation, it's a subcutaneous tender nodule. And if you diagnose it at this stage, you can avoid all this disfigurement. Of course, the diagnosis is based on biopsy. This is another type of chronic cutaneous lupus, also based on the pathology diagnosis. This is presenting as violaceous swollen plaques, non-tender, presenting over the head and neck and the upper arms. The differential diagnosis includes many other skin diseases, sarcoidosis, B-cell lymphoma, pseudolymphoma, so biopsy has to be taken. And if you notice, this patient on the left has a marking of a punch biopsy. Another rare type of chronic cutaneous lupus is chilblain lupus. It involves the cold parts of the body, like the ears, the nose, the fingers. It may ulcerate. Another type is the Rowell syndrome, which is the erythema multiforme. Like we all know that erythema multiforme is a drug reaction or is a reaction to herpes simplex virus. In that case here, it presents as erythema multiforme-like. The diagnostic feature is the targetoid rash over the limbs associated with oral and perioral lesions. And it is particularly affecting the palms and soles, and this is a diagnostic clue. This is a more subtle presentation we can see in our patient here. This patient also has the malar rash, which means she also had systemic lupus along with the Rowell syndrome. Another rare manifestation is bullous lupus. This also needs a biopsy because there is many differential diagnoses for the bullous dermatoses. It might be associated with lupus nephritis. Now we come to our second disease, dermatomyositis and polymyositis. I like very much this diagram because it summarizes all the pathognomonic signs of dermatomyositis and polymyositis. And this is a nice panel that was published to have a visual memory of all those signs. We start with the heliotrope sign and edema. Heliotrope comes from the name of this flower, and this inspires the name because of the lilac or the violaceous color of the eyelids of the patient. Please note that the erythema of the face does not spare nasolabial fold, unlike the lupus. This is a more subtle presentation in our patients. You can notice in the middle patient that there is involvement of the forehead. In the patient on the right, you can notice the facial erythema that involves the nasolabial folds. The Gottron's papules affect the knuckles of the hands, and this is a close-up view, and this is how it presents in more pigmented skin, and this is a more subtle presentation. The differential diagnosis for doctors who do not know well the Gottron's papules is warts, but warts rarely are that bilateral and symmetrical, and they rarely affect all the knuckles in that way, so it's easy for rheumatologists or dermatologists to recognize Gottron's. This is the Gottron sign. It's not a papule, it's just a violaceous discoloration of the elbows, knees, of the knuckles. This is an exaggerated discoloration on the right side of pigmented skin. The differential with the reverse Gottron of lupus is well clear. And this is a more subtle presentation to the right in our patients. Moving to the shawl sign, we can see on the left, and the sleeve sign, and the holster sign. And this is one of our patients. The V sign refers to the V area of the chest. Other characteristic but non-specific signs are, of course, the periungual erythema and telangiectasia, calcinosis cutis in advanced disease, and I think now it's rarer to see. This is very interesting because the seborrheic dermatitis-like presentation in the scalp is often confused with just simple seborrheic dermatitis. And this is the gum erythema. There are some rare signs of specific significance in some syndromes, like antithenstatase syndrome that manifests with mechanics hand, which is like a worker's, manual worker hand, dryness, and it looks like eczema. This is a flagellate erythema associated commonly with anti-Me2 antibodies. And this sign over the palate is associated with malignancy and anti-TIF1 gamma. This is one of our patients that presented with paraneoplastic dermatomyositis secondary to breast cancer. You can see the V sign, Gottron sign, heliotrope edema, and erythema and face erythema. Note that the nasolabial folds are involved too. Now we move to scleroderma. Just a rapid reminder, sclerosing skin disorders decline into so many categories. I will not discuss today the localized scleroderma or morphia because it's really out of the scope. Systemic sclerosis, I want only to stress on this part. The only diagnostic and truly meaningful diagnosis is the pre-scleroderma stage, where you really stop the progress of the disease in a patient who has Raynaud syndrome. And when you investigate with capillaroscopy and serology, positive ANA, positive capillaroscopy, this is the best therapeutic window for the patient with impending scleroderma. I will use the ACR EULAR criteria to show my pictures. So this is the puffiness of the hands that is the earliest sign and one of the phases of the disease where you can interfere early enough. And impending sclerodactyly. This is the fingertip ulcers and scarring. And this is the characteristic matte or square telangiectasia on the face. You can see on the face of the patient. You can also see it on the chest. And the capillaroscopic characteristic patterns on the bottom of the slide in comparison to the normal capillaroscopy pattern you can see in the middle. Raynaud's phenomenon, like discussed, if you investigate early with video capillaroscopy, this is really a good therapeutic window. Salt and pepper pigmentation is suggested by some published articles to be one of the earliest signs. This was not confirmed with later literature, However, it's important to bear in mind that it's easily misdiagnosed as vitiligo, as you can see. This panel shows how incapacitating the disease is. You can see the deformities of the hands and the xerostomia, which is the limited mouth opening of the upper patient, upper picture. Moving to rheumatoid arthritis. Rheumatoid arthritis is well known to be associated with rheumatoid nodules, although rheumatoid nodules are not specific to rheumatoid arthritis. You can see them in other autoimmune connective tissue diseases like lupus or dermatomyositis, but rarer. Those are asymptomatic nodules. Sometimes they may ulcerate. Treatment of patients of rheumatoid arthritis with methotrexate may sometimes accelerate rheumatoid nodulosis, which means appearance of nodules, multiple nodules in multiple body sites. And in that case, you need to stop the methotrexate treatment so that it stops the progress of the nodulosis. This sign is associated with severe active rheumatoid arthritis. Those are characteristically asymptomatic papules. They appear around the joints of the extremities of the limbs. I actually saw one patient recently, and to be honest, before I did this lecture, I did not know about it. And this is characteristically diagnosed by neutrophilic infiltrate in the pathology. This is pyoderma gangrenosum. It is characteristically diagnosed by the dirty floor, the pyogenic floor, and the undermining edges, and the surrounding erythema. And this is difficult to heal ulcer. Sweet syndrome may manifest in patients with rheumatoid arthritis. Along, like you see in the picture, there are also constitutional manifestations. While in reactive granulomatous dermatitis, there is no constitutional manifestations. It is a pathological diagnosis. The problem is vasculitis because it points towards systemic affection. And in rheumatoid vasculitis, usually it's medium-sized vasculitis, so it ulcerates more commonly. And in Felty syndrome, we can see necrotizing lesions and commonly skin infections. Moving to psoriatic arthritis, the variety of symptoms of the skin manifestations of psoriasis is really out of the scope of this lecture. I will just mention that nails, scalp, and palmoplantar psoriasis were found to be most commonly associated with rheumatoid arthritis. Sometimes they herald the appearance of arthritis several years before. You can always recognize the psoriasis skin lesions by the typical induration, erythema, and silvery white scales. I would like to move to Sjogren syndrome. The most commonly known symptoms are the Sicca symptoms, dryness of the skin and mucous membranes. The less known symptoms are the vasculopathic and vasculitic symptoms. This is livido reticularis, like we said before, a fixed network of erythema over the lower limbs that turns into pigmentation later on. This is leukocytoclastic vasculitis with the characteristic palpable purpura. And this is a vasculitis that evolves into ulcers. And this is the manifestation of cryovasc, which is cryoglobulinic vasculitis. And I like to mention that Professor Gaffer and co-authors coined a recent item of monoclonal gammopathy of rheumatologic significance. And this is the article, really interesting and really important, to focus on the B-cell clonality of associated commonly with Sjogren syndrome. We can also see amyloidosis. This is nodular amyloidosis. Systemic amyloidosis may coexist or not. Also erythema annulare centrifugum. This is a typical picture. If I remove the diagnosis from below the picture, you might think about tinea corporis, fungal infection. Yes, this is an important differential diagnosis, and that's why patients has to be referred to mycology tests. And commonly also erythema nodosum is seen in Sjogren, but also in many other autoimmune connective tissue diseases, characteristically tender hot nodules over the shins, and over any other part of the body is possible. Are we there yet? Please bear with me. I need to share with you here a few clinical tips for the differential diagnosis. So what do we do to diagnose photosensitive red rash over the face? First, we look on the specific skin signs. Here we can see sparing of the nasolabial fold, unlike here. Here we can see associated papules and pustules. Here we notice some yellow scaling. By examining properly the patient, you might find Gottron's papules or reverse Gottron's, which refers to lupus. In the middle, there is a report about inverse Gottron papules. Those are also happen in dermatomyositis, but they involve the palms of the soles rather than the dorsum of the soles. You can see other sites affected with this scaly erythema, like the flexures, the ears. And using dermoscopy is really, really helpful in those cases. So what's your diagnosis? This is acute lupus, dermatomyositis, polymyositis. This is rosacea, seborrheic dermatitis, and this one was found to be photosensitive dermatitis relevant to a drug reaction. What do you do when you see a patient with nail dystrophy? We say ugly nails, and the patient is desperate about it. Well, it's difficult to do something because clinically alone you cannot diagnose it. You can see how variable the presentation of nail psoriasis is, and it often imitates this one, which is fungal nail infection. As a matter of fact, you always need to exclude fungal infection, even if there is nail psoriasis and even if there is clinical skin and joint psoriasis. Why? Because there is common association between two conditions. So sending the patient for mycology testing is really worth it because patients has to take antifungal treatments for several months because of the imminent now emergent resistance to antifungals. You might also face one of those features. On the right, you can see signs that are commonly associated with rheumatoid arthritis. But the only one that was linked with activity was this one, pincer nail, which is described as, an increased transverse dimension of the nail. And the ones on the left are commonly seen in lupus erythematosus, while splinter hemorrhage was the only one linked to the activity. I would say that in any autoimmune connective tissue disease, periangual erythema and telangiectasia has to be properly addressed with video capillaroscopy for accurate and early diagnosis. What do you do when you face red, scaly skin, whether it is papulosquamous, like the one on the left, or annular, like the one on the right? There is no secret recipe. We have to go through all the steps. So a thorough history and total body examination and systematic review and dermoscopy. And sometimes, like the patient on the right, you have to exclude fungal infection in this kind of annular lesion. So you send your patient for mycology testing, and you might go to skin biopsy. Please keep your mind open to all possibilities. This patient was referred to me from my colleague, rheumatologist, for diagnosis of those tiny erythematous and scaly lesions over her body. By dermoscopy, I saw this patient was diagnosed as lupus erythematosus in the rheumatology office. By dermoscopy, I saw signs suggestive of psoriasis. So I sent the patient for a biopsy and it was confirmative. So this patient had lupus erythematosus associated with guttate psoriasis. So we agreed with my colleague in rheumatology to stop the hydroxychloroquine because, as you know, it precipitates psoriasis. And we changed her to methotrexate, which is a good treatment choice for both conditions. Are we there yet? Almost. I only want to remind you about the skin manifestations of drug complications. Systemic corticosteroids are used very often in rheumatologic patients, and this is one of the common manifestations that we can face. This is acneiform eruption. This is not acne. This is a close-up view where you see that all lesions are similar. We call this monomorphic lesions, papules and pustules. And you can notice in all three pictures, there is absence of black dots, which are the comedones. And this is how we diagnose acneiform eruption versus acne. Another complication, this is methotrexate toxicity that presents as mucocutaneous ulcers. Of course, we have to stop methotrexate and give the antidote folinic acid. Unfortunately, this patient was really well controlled on TNF-alpha inhibitors for her psoriatic arthritis, but then she presented with paradoxical psoriasis, cutaneous psoriasis, that forced us to change the therapeutic line. Hydroxychloroquine-induced melanosis, we can see it in clinical practice. It's characteristically gray to black pigmentation, commonly over the shins, but it can affect any body site. It can be reversible, but in our pigmented skin, it usually leaves residual pigmentation. We have this severe adverse drug reaction spectrum that starts with erythema multiforme. The specific targetoid lesions are diagnostic. It may progress to Stevens-Johnson or even to toxic epidermal necrolysis like the patient we saw before. Infections are very common in the immunocompromised patients, but this one is really one I would like to point. In the clinical practice, it is easily missed, easily diagnosed as eczema. And the patient comes with months and months of application of topical corticosteroids that does not cure the condition. Well, you have to keep in mind a high index of suspicion of tinea incognito, which is tinea unrecognizable because it lost its characteristic red rim the red rim is usually characteristic of fungal infection. In the other pictures, you can only imagine it, but you can't see it clearly. So in this lower picture of the feet, you can see this is asymmetrical affection. This is really a diagnostic clue of fungal infection. This is not eczema. And for the hands, we can imagine a red line, and this is a bit asymmetrical presentation. In those patients, please send for mycology testing, and it's worth it because those patients need antifungals for several months, even in the skin because of the emergent resistance, and you have to do liver functions every month to monitor under therapy. Common bacterial infections, cellulitis and erysipelas, they might affect the face too. And common viral infections, herpes zoster and warts. It's worth mentioning that not all the patients will respond to the classic oral protocol. In this patient of herpes zoster, I had to give her IV acyclovir to reach this stage. Skin cancers, this is my last slide. We should bear in mind that anti-TNF-alpha biologics really increase the incidence of non-melanoma skin cancers, particularly in the fair skin type. Here we can see actinic keratosis, well-developed squamous cell carcinoma over the lip, and basal cell carcinoma. Those are easy to diagnose, so this is not the stage I want you to diagnose the patient at. I wish you diagnose them at this stage. Those are my patients. This is actinic keratosis impending. How do you recognize it? Fixed erythema and scaling at the same spot for months and years. This is how you suspect it. So in those patients who are taking tumor necrosis alpha for long-term treatment, please, if they are patients with fair skin, it's even more a reason to refer them for annual skin screening. And actually, This middle patient here, it's a patient who was taking anti-TNF alpha and was never referred for screening because he never knew that this is a risk. To sum up, it's a bit hard to summarize such a lecture, so I will go forward to my references, and thank you very much.
Thank you very much, Dr. Vanessa Hafiz. This was very informative and very illustrative. I think we have to, just one question. Okay.
Thank you, Professor, for the elegant lecture. Mustafa Ali Saad, lecturer of internal medicine, Cairo University. Regarding toxic epidermal necrolysis, you presented, I think, the same picture in lupus. Yes.
For educational purpose.
Yes.
This is a very intelligent question. I just wanted not to change the picture. The one I presented in 10-like was actually a drug-induced one, but I wanted to present it in both so that you can recognize the similarity.
Okay. Thank you. My question is, how can you attribute this presentation to lupus in absence of any other systemic manifestations of systemic lupus? And in other words, is there any meaning of differentiating 10 versus secondary, the same presentation second to lupus in terms of management? Is there any difference in managing both conditions?
It's a good question. For the diagnosis part, it's through the pathology and immunohistochemistry.
There is a difference.
To differentiate, yes. As regards the management, it's a cytokine storm, whether it is drug-induced or lupus-induced. The only thing is that, sorry, in the literature, it is reported to have a bit less risk of mortality, but this is not reassuring because indeed, patients with lupus 10-like reached mortality rate. So it's really not important to tell. The importance is to treat symptomatically and to treat the cytokine storm. This is no differentiation up to my knowledge.
Okay, thank you.
Thank you.
Thank you, Dr. Hafiz. We all enjoyed your very nice lecture. Thank you. Now we move to the third presentation. Professor Maria Antonietta D'Agostino had some obligations and she entrusted Dr. Gerlando Natalello to present her lecture. Are you with us, Dr. Natalello? Hello?
Can you hear me?
Yes, I can hear you now.
Okay.
Dr. Gerlando Natalello, I will introduce you. First of all, how are you? And we are so pleased to have you with us to present this difficult topic. And we are expecting to hear very good briefing on this very difficult topic. Dr. Gerlando Natalello is a rheumatologist at the Fondazione Policlinico Gemelli, IRCCS, the Catholic University of Rome in Italy. His clinical activity focuses on patients with inflammatory arthritis and connective tissue diseases. Since 2024, he has been coordinating the cell therapy program for autoimmune diseases under the direction of Professor Maria Antonietta D'Agostino. We are pleased and honored to have you today with us, Gerlando. So I leave the stage for you to present your very so much anticipated topic.
So thank you so much for this nice presentation and really appreciated invitation to this beautiful review course. Also on behalf of Professor D'Agostino that unfortunately will not attend today. So can you see my slides correctly and my pointer?
Yes. Both.
Okay. Perfect. So we can go on. So this is my agenda for today. So I will start rapidly with some basics, some background for the CAR T cell therapy. So first, what is a CAR T cell? Basically, is a T cell, a normal T cell of our immune system that we engineer and we use some genetic engineer to express the so-called chimeric antigen receptor, that is the CAR, of course. So this CAR, in fact, is a receptor that has the scope, the main scope, to engage another cell expressing a specific antigen, and it is constructed to engage very specific antigen. So after engineering, this receptor is expressed on the surface of the T cell, and in fact, when the T cell is circulating, is now able to engage with a target cell. So the CAR will keep the two cells close, and the CAR will be able to start some intracellular pathways that will have as a result the apoptosis of the target cell. So after engaging, the T cells will do its normal work. So there are the cytotoxicity mechanisms that we all know through, for instance, enzymes like perforin and granzymes and cytokine production, or Fas and Fas ligand receptor mechanism. And the results will be the apoptosis of the target cell. So there are many techniques. So this is a technical background for the CAR based treatment, and in fact we have differences in all the phase of the production of the CAR T cells. So first, I will say that the engineering method could change. In fact, we could make the T cells express the CAR after transducing it with a viral vector. That is the most common method, and we normally use lentiviruses for this reason. We can use lipid nanoparticles to deliver mRNA to make the T cell express the CAR. And finally, we could use the CRISPR-Cas method to make the CAR T express the CAR. Another important thing, the type of procedure to obtain the initial T cells to be engineered. So we have the autologous, so the cells are from the patient. We can have the allogenic, and this is really new. We could also have the in vivo engineering, delivering lipid nanoparticles. And finally, we talk mainly about the T cells, so CAR T cells, but in fact, other immune cells with cytotoxic capabilities are starting to be used for this kind of cellular therapy. So, for instance, T gamma delta cells and NK cells. So it's important to disclose that right now, most of the data that we have in the humans, and that of course I will show you, I will say 90% are from viral vector transduced T cells from autologous type of procedure, and of course they are T cells. But we are starting to see also allogenic and CRISPR and NK cells. So based on what is the most common method, just to give you a background, this is all the production phases of classical CAR T cell production. So we start with the apheresis to collect the autologous T cells, and then there is the production phase in which we insert the construct with a lentivirus normally in the T cells. Then we expand them, and we are ready to reinfuse in the patient, but before normally there is a lymphodepletion step because it is needed to make some space in the lymphoid organs of the patient before the reinfusion. And normally this is with cyclophosphamide, and fludarabine is really the standard for this step. So we have, of course, a longer track record in oncohematology. So from 2017, we had approved and reimbursed product from FDA for hematological cancer. And basically, the two main targets are always B cells, but with two different antigens that are CD19s and BCMA. And I will say that thanks to the track record in oncohematology, as a rheumatologist, we had really a big advantage because, as we know, the B cells are really important in our diseases. We know that B cells are central in the pathogenesis of many of our diseases through different mechanisms. We know for sure autoantibody production, cytokine production, but also stimulation of other autoreactive immune cells through antigen presentation and co-stimulation. And in fact, we have many prototypical B-cell-driven diseases. Of course, we have classical rheumatological diseases like the lupus and the rheumatoid arthritis, but it is of great interest also for neuroimmunologists because we have a lot of autoimmune diseases that involve peripheral and central nervous system. And looking at the B-cell development, or the lineage development, we can see that starting from progenitors arriving to mature and peripheral tissue cells like the memory B cells and the plasmablast and plasma cells, there is big heterogeneity of the antigens that T cells express. And it is very important that targeting CD19 and BCMA, in some way we can have the full range, we can target the full range of all the differentiation of B cell. And when we look, for instance, at CD20 that we used to target with, for instance, the rituximab, we can easily understand that we are not covering the entire spectrum of B-cell lineage. So that's, I think, one of the first big advantages of this new cell therapy with CAR-T. And here, just to put on another perspective, of course, we have different methods of B-cell depletion, but the CAR-T is the one that ensures the less residual B-cells for what I've already told you just before, but also because we have here a living therapy. So it's much easier to have deep penetration in tissues and B-cell depletion also in secondary lymphoid tissue with CAR-T, compared, for instance, to classical antibody-mediated killing, like, for instance, it will be here with the rituximab, or even with the new bispecific T-cell engager. There are something in the middle between the two approaches. And of course, in this way, we are going to block all the mechanisms of disease that we already seen before. So another quick technical note, and then we will switch to the more clinical interesting data. We have different generation of CAR construct. They are not the same. So we have the first, that basically generation is just composed by the extracellular domain that recognize the antigen and just signal transduction domains. That throughout the generation, we added co-stimulatory domains, like in the second, and in the third, in which we have two co-stimulatory domains. And now we are getting really new constructs that are able to induce directly production of cytokines to improve the killing response, or directly nuclear STAT3 and 5 activation, always to improve the killing of the target cells. But now we are using in the clinical trial just the second and third generation right now. So as you can see, these are all the used construct, both commercial and non-commercial, that right now are available for in the clinical studies. So just to disclose an important thing, so that you may have that is understand, there are no approved CAR-T therapies so far, because everything that I will show you is ongoing phase 1 and 2 trials. So the clinical evidence to date, everything started in 2021 with the first case report from Erlangen, Germany, of the case of severe systemic lupus erythematosus responding to anti-CD19 CAR-T. So after a single infusion, the authors reported over time, and I would say quite quickly after infusion in less than 2 months, response over different components of clinical activity of the disease. So after this, we had from the same authors also a case report on other 5 patients that reported the clinical efficacy, again, reducing clinical activity, and also they started to show some very interesting biomolecular data showing an immune reset in this patient. So that I will show you better later. And also a good safety profile in these first SLE patients. So after these 2 publications, we were prompted to go on, and there was a lot of interest, both from the academic point of view and commercial point of view, on go on with CAR T therapies. So this is this is what we are right now. This is the last review encompassing all the published treated patients, and this is from the beginning of 2025. So for sure there are new cases too, but this is a good snapshot of what we have right now. So 24 studies, that 9 clinical trials that are of course all phase 1 or phase 1/2, and then there are case series or case report. So far 80 patients reported, most of them treated with anti-CD19, all with lymphodepletion with cyclophosphamide and fludarabine preceding the CAR T. And these are the patients. So we have most of them SLE, but also we are starting to see scleroderma and inflammatory myositis, rheumatoid arthritis, primary Sjogren's syndrome, and antiphospholipid syndrome. And the conclusion of this literature review is that unfortunately, of course, we have no controlled study yet, and all the data due also to inconsistencies and different endpoints. They are difficult to compare and also to do a quantitative analysis of the effect size. Still, in fact, we have favorable data on efficacy and short-term safety for this kind of therapy. And in fact, we had mostly favorable clinical response in absence of negative outcomes. So no deaths related to the CAR T therapy until now. And I made a quick research yesterday on clinicaltrial.gov, and in fact, there is a very active field. We have now 154 active studies intervention. So we will see for sure very interesting data in the close future. And just to dissect a bit more the efficacy aspect of the CAR T therapy, I want to take this publication, this case series that is the big so far with that is consistent in terms of construct usage, and is from the same court from Erlangen, and there are 15 patients. So it's good to analyze some data just to check what are real efficacy clinical data here. So as you can see, we have 8 SLE patients, 4 scleroderma, and 3 inflammatory myositis. And in fact, one of the things that I want to point out, some of them, they were treated already with rituximab. This is not a contraindication for this kind of therapy. And there are good data also on this subset of patients responding well, even if they failed rituximab treatment. And of course, all these patients had kind of severe disease and refractory to at least 2 different immunosuppressive therapies plus glucocorticoids. So they are patients with not a very good prognosis. So what about the short-term efficacy? We can see that, of course, in each subset of patients, SLE, inflammatory myositis, and scleroderma, we have specific subset of endpoint to look at. But in fact, what is important, and that all the patients, regardless of the diagnosis, reached the prefixed endpoint of remission. And in fact, most of them, except for scleroderma, but for lupus is DORIS remission, and for the inflammatory myositis is the major clinical response from HULAR. That means that is in fact as a true remission, is almost absence of clinical signs of the disease. And another important thing is that all the patients, they have glucocorticoid-free and immunosuppressive drug free status at the follow-up. Regarding scleroderma, they did not have a true remission score because that is a very particular disease where you have, fibrotic burden. So they just looked at the change in the EGYSIR AI score and in modified rodent skin score. And what you can see that there is in all patients a reduction in these two endpoints. This is to look more also on the looking at the time to the onset of different clinical effects. So as you can see, most of the endpoint were reached after around 3 to 6 months. On the left, for instance, you have all the parameters for SLE. The same is for inflammatory myositis, in which you can see also some serological markers like the creatine kinase, very important markers, and the same for the scleroderma. You can see some response around 3 months, but then you will have something up to 6 months normally. And what is important too, we have biomolecular and cellular data that show that we have an early reconstitution of B cells, but when they reconstitute after the first phase of B cell aplasia, we have a naive subtype of B cells. And this is maintained also after the established reconstitution. So this is a point in favor of a true immunological reset after the CAR-T treatment. And of course, we have naive B cells, but we, of course, have a really reduction on the other side of the mature form, like the plasmablast or memory B cells. And as you can see, there is also serological response for almost all the antibodies specific for each disease. And after a few months, after 6 months, you can see there is under the lower limit to be positive for most of the antibodies, with the exception of anti-topoisomerase 1 for scleroderma that was not very easy to remove from the serum after CAR-T treatment. And at the same time, you can see this is very important. The patient after CAR-T treatment, they are still able to build response. For instance, if you do vaccination, or in this case, if there is a SARS-CoV-2 infection, it was the case for 2 patients. So after early reconstitution, the B cells are really functional and in a good way in terms of immunization. And this shows really well. This is an important study too, because shows the comparison with rituximab and CAR-T anti-CD19 therapy. So you can see that looking at peripheral blood changes, as we know, the rituximab has a good effect in giving us B cell aplasia in peripheral blood. But the very interesting thing is when we look at the lymphoid organs, so lymph nodes, here you can see the true differences. And with rituximab, you don't have a deep depletion of the B cells. You can look here at CD19 positive and the CD20 positive, but with the CAR-T, you really have a profound depletion, and you have also a different morphological aspect and reorganization of the lymphoid follicles. So that's very important. It gives us really the idea of the capacity of the CAR-T to penetrate deep in the tissues. And just a brief report about the fact that also allogenic cells, as I told you, they are starting to be developed. And in fact, the process of engineering is a bit more complicated in the allogenic CAR-T cells, because after you do the transduction to give the cell the CAR construct, you have to be sure that you have to be sure that the cells are not rejected, like with graft versus host diseases, or that they will give immunogenicity to the receiving patient. So you have to do a second engineering step with CRISPR to remove all the HLA-related surface antigen and PD-1 and PD-L1 molecules. But in fact, also here we have a very, I won't show you for the sake of time, the extended data, but you can see that in the one patient with the inflammatory myositis and 2 patients with scleroderma, you had very impressive response, both from imaging, from really objective data, like muscle MRI and lung CT scan, and no safety concerns compared to the autologous CD19 CAR T. And what happens if there is a relapse? So it seems it's very rare, at least in the observation that we have so far, that is around 3 years, to have relapse after CAR T. But it happened in one case. And what the authors did, here you can see that they tried to treat another time with this CD19 targeted CAR T, but they have loss of response, completely loss of response, so no expansion of the CAR T cells and not B cell aplasia after the second shot of CD19 CAR T. So what they did is to change the targets. So they infused anti-BCMA, so always B cells, but on another antigen. And this time they were able to restore the remission in these patients with inflammatory myositis. So this is important because it tells us 2 things, that it is possible also with the autologous CAR T cells to have immunogenicity against the CAR T construct that will hamper the response, but that if we switch the target, we can restore a very good response in these patients. So some safety and practical consideration, I think this is a very important part because in fact, right now we are in the phase 1 and 2 trials. It means that we are checking more for the, of course, we are looking to the efficacy, but we are really checking the safety too. So we can look at the short term, and I will focus more on the very important side effects that are the cytokine release syndrome and the neurotoxicity, because they are the most common and important one. And in fact, if we look at the data from hemato-oncology, the data are not really reassuring. We have high rates of cytokine release syndrome and central nervous system toxicity, and also a high rate of the for severe form. But in fact, the good news is that for the, as I will show you in a minute, for in autoimmune disease, this is not the case. So what is the cytokine release syndrome? Is a very self-explaining, the word. So in fact, is a systemic reaction that we can compare to a very severe inflammatory response syndrome that is based on the lysis of the target cells. So and our mass release of cytokines in the circulation. So this will give a very important inflammatory systemic response. So what it is intuitive, and that it was then demonstrated in some study, is that since the cytokine release syndrome is mediated by cytokines released from lysed cells, when the burden of target cells is higher, so in other words, if for instance the tumor mass is very big, there will be a more severe cytokine release syndrome. So that's a very important point to understand then why in autoimmune disease we don't have this very important cytokine release syndrome, because of course the burden of B cells that we are going to target is much less if we compare, for instance, to a lymphoma, of course. And what is the neurotoxicity associated to immune effector cell? Basically is again our inflammatory response, but when we have cross passaging of cells or cytokines mediators through the hematoencephalic barrier, we will have also the neurotoxicity that is can have a very bad prognosis. And as you can see, these are data from the first patients treated with CAR T immunological patients. We have the peak of CRS and ICANS around 10 to 14 days, and it corresponds to the peak of CAR T expansion in the blood, and correlates also with the peak of cytokines that precede the T cell expansion. So we have a grade also to manage in the clinical practice the CRS and the ICANS. We have 4 grades, and the first 2 are considered the mild, and we can manage with minimal intervention, but the 3 and 4 requires the management in intensive care units. And as you can see, after grade 2, we have to use tocilizumab and dexamethasone at high dose just to switch off this very high inflammatory process. And this is, as I anticipated you, the good news is we look at the Erlangen cohort, that is the most, the wider cohorts up now. We can see that CRS is common in patients, but is of mild grade. So it can be managed with conservative and minimal therapy and has no consequences on the patient. And the ICANS, it's very rare, just 1 patient in over 15 patients treated at ICANS, and is mild. So it's completely different to what we see with hematological malignancies. So a quick snapshot of also of the long term. So in this cohort, we have infection, but they were all mild, as you can see, with predominance of upper respiratory tract infection. And to manage this, we have also prophylaxis that we give to all the patients with infusion of CAR-T, that is antiviral, valacyclovir and cotrimoxazole for the pneumocystis carini, that we give for 1 year after the infusion. And this is compulsory. And then we have the possibility to give other drugs and immunoglobulin also supplementation just in case of severe infection, but not compulsory. And very quick, macrophage activation syndrome as a consequence of, but is 3.5 with high mortality in oncohematologic patients, and it's very difficult sometimes to distinguish from the underlying hematologic malignancy or from CRS. And another important thing is that we can manage in the case it occurs. And then this is a really important discussion point, especially in oncohematology field. The second primary malignancies after CAR-T, there is a rising concern that this kind of therapy that could give some cancer, some new cancer after, so not the relapse of the pathology that has been treated, but a new cancer after CAR-T. And there are some big registries that show that, in fact, over time, there is an increase in the incidence of cancer. And with, you can see here, predominance of hematological malignancy, and fat myelodysplastic syndrome, and acute myeloid leukemia, and T-cell lymphoma are the most common one, but also solid malignancies like the carcinoma and sarcoma. But in fact, there are some signal that this cancer could be associated to the CAR-T treatment. And as you can see, most of them develop in the first year of the disease. So 75% of these incident cases is in the first 500 days after the CAR-T, and the rest is slowly increasing after the 500 days post-CAR-T, with earlier appearance for the hematological cancer. But at the end, we have not yet very solid data about this, because they are all the registry data, the best we have. So it's not possible to infer a causal relationship. And also, when we look at the comparison with other therapies that we would normally do if we don't do the CAR-T, these signals are much less evident. So right now, it's not quite the main concern about this kind of therapy, because the patient still, the risk-benefit ratio, it seems still favorable, also with this signal from second primary malignancies. And important for us in autoimmune disease, we have, of course, a less track record, but no second primary malignancies or macrophage activation syndrome has been reported so far in autoimmune disease treated with CAR-T. But finally, what I want to to tell you, because it's something specific that was unknown before, is the local immune effector cell toxicity that is specific for autoimmune patients. And this is an impairment of organ function after CAR T infusion in an organ and in a tissue that is already impacted by the disease. So in other words, if a patient with SLE, for instance, had kidney disease, we can observe after CAR T infusion in the first phase a worsening of the kidney damage. And this is appear to be very common. So in this, this is the always the Erlangen cohort. In 39 patients, 77% had this kind of local toxicity. So most of them in the kidney because we were SLE with nephritis, but also in skin, muscle, heart, lung, and joint. And as I told you, that the very important concept is that something that happened in the organ that is already impacted by the disease, and there is a transient worsening in the organ damage that usually appear around 20 days after CAR T infusion. And as you can see, there is a peak, for instance, in serological markers when we look at, for instance, renal function or muscle enzymes and included troponin. But then there is a complete restoring, and also we go below the baseline. So after this first phase, we have remission of the disease. And these are some photo of, for instance, skin reaction that then have been treated with low-dose glucocorticoids, and also on the local reaction to lungs. And in fact, the severity of this of local reaction is normally mild. And in fact, there is no association with baseline disease activity of CAR T cell expansion of time of B-cell aplasia or CRS. So to wrap up this, the local immune effector cells is a newly described syndrome, toxicity syndrome in autoimmune patients, but fortunately is usually mild, is self-limited or responding to low-dose glucocorticoids, and is transient. And the mechanism, probably, it has been hypothesized, is the cleansing of immune cells from the affected organs, because we always see in the organ in which the disease is already before. So what we have to do now, we have to get better CAR T therapies. So to do this, we have to increase the bioavailability in the tissue. We have to increase the persistence of the CAR T that now is limited to less than 1 month, so to have even deeper depletion. And we have, of course, to decrease cost and make more accessible this kind of therapy and reduce the toxicities. So most of these objectives can be achieved improving the construct, so developing more new technological solution for the for this kind of therapy. And I showed you data on disease that are interested primarily for the rheumatologists, but right now also the neuroimmunologists, they are starting to look at this kind of therapy, and type 1 diabetes too, and also inflammatory bowel disease. So some of these other non-strictly rheumatological disease, we are starting to have some clinical trial with different targets. And this is my last slide, just to give you perspective of the technological evolution. Right now, we are doing the chimeric antigen receptor, the classic CAR, but we are going to have the objective that I told you before, to have more precise and restricted kind of construct. The first one is the CHAR that is restricted just for autoreactive B cells through a HLA antigen expression. And another even more precise is the CAAR that is restricted only to B cells that express specific antigen. So this will be very, very personalized and precise when we will have in the clinic. So just to resume, we can say that targeted B-cell therapy with CAR T has shown very promising results in patients with autoimmune disease, severe and refractories. And preliminary data showed the deep depletion in secondary lymphoid organs, leading to deep and drug-free remission after a single administration. And relapse is still possible, even if it is rare. And in this case, we can change the target, for instance, from CD19 to BCMA to restore the remission. The safety profile so far is favorable, better than for hematological tumors with regard to classic CRS and ICANS. But we have to be cautious about the specific toxicity, the lichens, that is due to cleansing of autoreactive cell in the tissue. And of course, we have to wait for long-term data about safety efficacy that are currently not well known. And continuous improvement is warranted to have more better objective with reducing toxicity, improving tissue penetration, and the reduced cost, of course, to have better accessibility to this kind of treatment. I thank you for your attention.
Thank you very much, Gerlando. Any questions? Yes, Dr. Tommy. Please present yourself.
Mustafa Tomi, Ahmed Meher Teaching Hospital, Internal Medicine Consultant. Thank you, sir, very much for your nice talk. I want to ask about, you have any trials about using CAR-Treg to induce immune tolerance?
Yeah. So this is a very new field, and they are working on it, especially in the, I will say, in the inflammatory bowel disease field right now. So the concept is kind of different in such compared to what I just showed you, because here we are going, what we are doing right now is going to kill some autoreactive cells that we don't want anymore. But in case of T regulatory CAR, there is the CAR is against an antigen, but the scope is to get the regulatory T cells localized in a specific tissue. So, for instance, we have inflammation in the gut. This is the most compelling example because they are developing for IBDs. We want to localize regulatory T cells in the gut, so we have to express CAR, but not to kill a specific type of cell, but to localize in that specific tissue where we want the regulatory effect, so to dampen the inflammation. So this is a very promising approach, but so far we have really only preclinical data that I know. So there is a lot of things to do yet. And of course, we can think of something similar also in our disease, I guess, to expand, the kind of disease target, because right now we are on B-driven diseases, but with this kind of approach, we can expand, for instance, to spondyloarthritis and to other maybe more T-cell driven diseases.
Thank you.
Very interesting.
Thank you very much.
Okay, any more questions? I think we have come to the end of this presentation. Thank you very much, Dr. Gerlando.
Thank you.
Natalello, I think you covered the topic completely, that there are no missing points to understand now. Thank you very much, and hope to be hearing you again in the future.
Thank you. Bye.
Our next presentation will be with Dr. Shinji Izuka. Dr. Shinji Izuka, can you hear me?
Yes, I'm here.
Okay.
Yes.
Okay. Welcome. We are proud and happy to have you with us today. Can I introduce Dr. Shinji at first, and then I leave the stage for him for his presentation. Dr. Izuka is a rheumatologist scientist at the Department of Allergy and Rheumatology, the University of Tokyo, Japan. His research focuses on multiomics analysis of idiopathic inflammatory myopathies and SLE. He also serves as an ACR International Advisor and is the social media editor for RMD, Rheumatic Musculoskeletal Disease Open. His dedication, as he expresses it, in his own words, targets the ultimate goal of achieving precision medicine for better patient care. Dr. Izuka generously offered to present antisynthetase syndrome update from phenotype recognition to precision therapy. Thank you very much, Dr. Izuka, for your kind offer, and I leave the stage for you for your presentation.
Thank you very much, Professor Raghav, for the kind introduction and invitation. I'm very pleased to honored to be this wonderful meeting and this opportunity. I'd like to share the recent updates of antisynthetase syndrome today. So I will follow this agenda. I will touch on the overview briefly and newly developed classification criteria for antisynthetase syndrome and the heterogeneity that's showing the different clinical endotypes among the antisynthetase. And we also have the new guideline for the malignancy and interstitial lung disease management. And I will deeply focus on the treatment strategy based on the pathogenesis of antisynthetase. So as you may know, idiopathic inflammatory myopathies include various disease phenotypes such as dermatomyositis, idiopathic necrotizing myopathies, and overlap syndrome. And antisynthetase syndrome, which show the positivity for the antisynthetase antibodies, is one of this kind of disease phenotypes. And the antisynthetase syndrome frequently develops the interstitial lung disease, as well as skin rash, myositis, arthritis, and mechanic hand and renal phenomena. But importantly, some patients can only have the lung disease with no other muscle involvement or other symptoms. So let me share the new nomenclature of antisynthetase syndrome. This was published this year by the International Myositis Assessment Clinical Study Group, IMAX, which is one of the largest myositis association. And they define that antisynthetase syndrome and ACEs as preferred terms. So I will follow this throughout. So let us think about the typical case of the antisynthetase syndrome. For instance, 55-year-old women who have the dry cough and dyspnea with the mechanic sound. And HLCT shows the NSIP pattern of interstitial lung disease. Patient will also have the myositis and positive for the anti-Jo1 antibody. As you may think, this is the antisynthetase syndrome, which is easily to imagine this disease. But unfortunately, there are no specific criteria for diagnosing the antisynthetase syndrome. So more than 50 years ago, the Bohan and the Peter criteria was published that include only the polymyositis, dermatomyositis, and overlap myositis. Possibly the antisynthetase syndrome can be included within the dermatomyositis in this criteria. And more recently, about 8 years ago, 2017 EULAR ACR criteria for the idiopathic inflammatory myopathy also include the IMNM, IBM, dermatomyositis, and not antisynthesis. We lack the validated classification criteria for antisynthetase syndrome. However, there are some proposed criteria, like one of that includes the antisynthetase antibody positivity, plus one of the following: interstitial lung disease, myositis, arthritis, and cutaneous symptoms. Okay, so referring to the criteria which I mentioned, this patient can be identified as the antisynthetase syndrome because this patient had mechanic sound, NSIP pattern, interstitial lung disease, and Jo1 antibodies. But and let me think about this case. Almost the same patient, but the patient who have not mechanics hand, but VNX rush, and not NSIP, interstitial lung disease, but UIP pattern. How do you diagnose this patient? So this is not the typical case of antisynthetase, but do we have the data for that? To answer the question, the CRAS project, which is one of the projects from IMAX, which I mentioned earlier, is trying to identify what kind of clinical features are more specific for antisynthetase. This project includes about 1,000 patients with antisynthetase and 1,000 patient, 1,000 controls to compare the clinical features. And this study shows that the arthritis, but not the isolated arthralgia, are associated with the antisynthetase. And also NSIP and OB pattern interstitial lung disease are more deeply associated with the ACEs and mechanics hand, renal, and fever, and antinuclear antibody pattern of cytoplasmic pattern is the more associated with antisynthetase. So these features should be incorporated into a newly developed criteria. So this is a candidate classification criteria for antisynthetase, which was presented ACR last year. And this included inflammatory arthralgia or arthritis. Information is important to get the score for antisynthetase. And as for the interstitial lung disease, UIP pattern had the low score, but NSIP and OB pattern have the high score. And the mechanic sound, high food, and the cytoplasmic antinuclear antibody staining pattern also have the high score. But currently, this is under development. This is not the final version of the classification criteria. And as I mentioned, cytoplasmic pattern matters, and measuring antisynthetase antibodies itself is also important because, as shown here on the left panel, the upper panel shows the cytoplasmic staining. Patient with antisynthetase show the cytoplasmic pattern because the autoantigen, which is the amino acid synthetase, exists not in nuclear but in cytoplasmic. So this reflects such features. And indeed, 50 patients with antisynthetase showed the positivity of anti-nuclear antibody, but 72 patients, majority of patients showed the positivity for anti-cytoplasmic antibodies. So, and this staining pattern is a clue to diagnose antisynthetase. But let's think about these cases. The patient who have the anti-MDA5 antibodies with the rapidly progressing NSIP pattern, interstitial lung disease, and the myositis, arthritis, and the DM rash, and the renal phenomenon. This patient also can be classified as antisynthetase syndrome with this newly developed criteria. And also the case of the anti-U1 RNB antibody positive patient who have NSIP, myositis, pre-arthritis, and inflammatory losses. This patient also can be classified in the antisynthetase syndrome using this criteria. So we need more precise criteria that also address this kind of heterogeneity. And more challenging thing is, as I mentioned, antisynthetase is a quite heterogeneous diseases. There are some clinical endotypes. So one of the clues to identify the differences in clinical phenotype is autoantigen. So as you can see here, this is the amino acid transfer RNA synthetase. which is the autoantigen of antisynthetase syndrome. This enzyme, which is located in cytoplasmic, have the function that combine amino acid and the corresponding transfer RNA to produce the amino acids at the end of the day. And of course, the amino acids show the variety as shown here. The Jo1 is corresponding amino acid histidyl. This has the classical triad of the antisynthetase, but PL7 and PL12 tend to show the severe ILD and lower survival rate. And the OG antibody have the trend to have the malignancy, and the OG antibody is associated with acute onset interstitial lung disease and the lower poor prognosis. Although these autoantibodies differences can be a clue to distinguish disease phenotypes, this is the cohort study from the China that includes almost 700 patients. That shows there are no significant differences in terms of prognosis among the antisynthetase as shown here. So this means autoantibody alone does not capture disease heterogeneity. Again, let's think about this case. 55 years old women who have the progressive worsening dyspnea over several weeks and make an exam and SIP. This patient, the major problem in this patient is rapidly progressive interstitial lung disease. It's obvious. But how about this case? This kind of patient can be classified as antisynthetase, patients who have antisynthetase antibodies with the heliothoracic papule with the myositis. This patient, the features of this patient include the dermatomyositis like skin rash and myositis. And this is a very typical case of antisynthetase who have the muscle weakness, NSIB pattern interstitial lung disease, and arthritis, and elevated creatinine kinase. So this is also from the cohort study from China that stratified a patient based on the clinical phenotypes. The endotype is rapidly progressing interstitial lung disease cluster, and the endotype 2 is the dermatomyositis like skin rash, and endotype 3 is the very typical cases of antisynthetase. Interestingly, the prognosis differ if we stratify the patient based on these symptoms. And the cluster 1, rapidly progressive ILD cluster, had the poor prognosis, and the typical case of the antisynthetase showed the favorable prognosis. And how do we apply this study into clinical settings? This is the most important thing, I think. The respiratory failure and the V sign, show sign, these three features, using these three features, we can stratify patients into 3 groups with high accuracy. So this is very practical and useful to predict the patient's prognosis in real clinical settings. Let me briefly touch the malignancy risk next. So as I mentioned, the antisynthetase syndrome is a very difficult disease, and the treatment also we think we have to think a lot when we consider the treatment strategy. But as for the malignancy risk, antisynthetase syndrome and anti-Jo1 antibodies are included in lower risk factors in cancer myositis associated cancer screening guideline from IMAX, which was published last year. So this is really reassuring fact. Indeed, this is the data from our university that demonstrate that of course, within the few years of diagnosis of the patients, and there are lower risk of malignancy in antisynthetase. But more importantly, although the MDA5 dermatomyositis patient had a higher risk of malignancy in the longer term, antisynthetase does not show this trend. So we can say that we can observe the lower risk of cancer in patients with antisynthetase in shorter term as well as longer term. And this was a case from the French cohort. And among the 120 patients, only 14 patients had the antisynthetase, and the risk factors of developing malignancy is older age and cancer history. So of course we should screen for the malignancy for patient with antisynthetase. We don't have to be careful about the cancer seriously, like for the patient with anti-MDA5, anti-TIFN gamma. So next, what about the interstitial lung disease? This is most important symptom in patient with my antisynthetase. So this is the European Respiratory Society and the EULAR clinical practice guidelines for CTD-ILD, which was published a few days ago. And this guideline proposes that we should screen the for the interstitial lung disease for patient with all myositis patient, especially for who have the risk factors. These risk factors includes the antisynthetase, so we need to screen all patient with antisynthetase, and this is antisynthetase antibodies also referred as poor outcome risk factors for poor outcomes. Now, in addition to HRCT, we should perform lung function tests, 6 minutes walk test, and the patient-reported outcome measures are also important to determine the treatment strategies. And lastly, I wanted to deeply focus on the treatment strategies today. So the current treatment strategies are supported by limited evidence. As shown here, there are some guidelines published from across the globe. But these guidelines are heterogeneous in treatment approaches, and we need to develop global consensus-driven standardized guidelines. So of course, we have the treatment. One of the recommendations from the European Neuromuscular Center, ENMC, and other publication, these medications are proposed to treatment for the antisynthetase. And of course, the glucocorticoid is a first-line therapy, and the doses should be the 0.5 milligram to 1 milligram per kilometer. And as a sparing agent, mycophenolate and calcineurin inhibitors can be effective for the interstitial lung disease and skin or myositis and joint. And in this recommendation, the typing there's an alternative option. And recently we gradually use the abatacept rituximab as a biological therapy. Abatacept might be a benefit for the long-term phase, and rituximab can improve the myositis and used for the progressive interstitial lung disease. And IVIG and cyclophosphamide are effective for the acute exacerbation of myositis and the interstitial lung disease. We use this kind of treatment in the severe cases. And JAK inhibitors also try to treat the patient with antisynthetase. And also we should consider the antifibrotic agents such as nintedanib and pirfenidone. Needless to say, we should care the non-pharmacological approaches such as aerobics, exercise, rehab, and vaccination and smoking cessation. But as I mentioned, we do not have the large-scale randomized controlled trial, and this practice guideline or recommendation largely rely on the expert opinion-based level. So we need a pathogenesis during treatment strategy. So we would like to focus on the pathogenesis. So when we think about the pathogenesis of antisynthetase syndrome, in addition to the genetic background, infection or tissue damage to the myocyte and lung leads to the MHC class 1 activation and autoantigen expression, and leading to the CD8 T cell activation. And this also promotes interestingly, the release or secretion of amino acid transfer RNA synthesis, which is the target of antisynthetase antibodies. And this leads to the antigen presenting cell and CD4 positive T cell activation. And this also ended up into the immune complex internalization to the cells, and transfer RNA triggers the Treg receptor 7 or 8 signaling and interferon release. So we need to target these cells. In our university, we conducted gene regulation, address gene expression, and the genetic data analysis of 28 immune cells, as shown here: T cell, NK cell, B cell, monocyte, dendritic cells, and so on, among the patient with various autoimmune diseases, including IIM. And as you can see here, myositis show the upregulation of interferon alpha and gamma, like MCTD and systemic lupus erythematosus. So from here we can say the interferon signature is enriched in myositis. And we also conducted the muscle transcriptomic analysis. Again, we found that upregulation of interferon and interferon alpha and gamma enrichments in muscle, and also in antisynthetase, the mitochondrial function is activated. This was published from the group in the from the NIH. Also shows the upregulation of interferon type 1 and type 2 interferon compared to the IM and M, but not as high as dermatomyositis, but still antisynthetase also showed upregulation of interferon signatures. So in addition to T cells, we should focus on the target the interferon signatures. And next, what about B cells? This was also from our department, showing that the plasmablasts, which is the main source of antibody production, showed the interferon upregulations compared to healthy control, and the oxidative phosphorylation signature was higher compared to MDF5 and MI2 antibody positive dermatomyositis. And also the double negative B cells and the memory B cells that are also the source of production of autoantibodies at the higher cell cycle and ER stress. This means that the antisynthetase syndrome patient shows the upregulated interferon signatures and the metabolically activated B cells. So here we show the T cell, B cell, and interferon can be a target for treatment of antisynthetase syndrome. As you can see, the T-cell targeted therapy includes calcineurin inhibitors and abatacept. And the B-cell can be targeted by rituximab and efgartigimod, which was newly developed treatment. And again, we just run the CD19 and BCMA CAR T-cell therapy, and as an interferon targeted therapy, JAK inhibitors, and also dazukibart is a newly developed biologic targeting interferon beta. So this is also the ACR and the CHEST guideline for treatment of interstitial lung disease for myositis. As initial treatments, as we discussed, rituximab and the calcineurin inhibitors were raised as the first-line treatment therapy, and as additional options, targeting the interferon and JAK inhibitors are recommended, and in severe cases, cyclophosphamide are also recommended. And in the severe and the progressive interstitial lung disease, again, rituximab and the calcineurin inhibitors, as well as the cyclophosphamide, IVIG, and JAK inhibitors were a treatment option. And we should remember that nintedanib, which is antifibrotic agent, should be considered to dampen the fibrosis. And in this recommendation, calcineurin inhibitor has been beneficial in refractory interstitial lung disease. This statement was written, and actually in Japan, we usually use the calcineurin inhibitors for treating a patient with interstitial lung disease with the myositis. And again, this is the European Respiratory Society and the EULAR clinical practice guideline for CTD-ILD. Again, calcineurin inhibitor and rituximab strongly recommended for treatment of ILD in myositis. And in high risk of progression, including MDR5 and antisynthetase, should be considered administering the cyclophosphamide and the rituximab, calcineurin inhibitor, and IVIG. Again, nintedanib recommended for the antifibrotic agents. But importantly, this recommendation describes we should avoid prolonged high-dose steroids. So we should administer timely these immunosuppressants and try to reduce the glucocorticoids as fast as possible. Okay, let's think about other T-cell targeting therapy, abatacept. This is the report from China last year. 8 patients with antisynthetase syndrome. This is the pre-treatment, and then this is after treatment. This report conclude that the abatacept can improve the lung function test and reduce the symptoms. And next, what about JAK inhibitors? This is a very small cohort, MyoJAK study, that also includes the antisynthetase, but this is very limited patient included. But when the patient who compared between the immediate baricitinib start group and the delayed start group, 23% of patients achieved primary outcome, which is measured total improvement score, showed a very preferential results of baricitinib for the treatment for myositis. And this is the case report by a 57-year-old man who have the anti-EGYSIR antibodies. Again, this shows the very impressive clinical course. Upper panel showed the before the treatment, and the patient have the mechanics hand and high cuff feet. And after the administration of baricitinib, these symptoms resolved very clearly and beautifully. Next, other newly developed treatment of EGYSIR. This is the interferon beta specific monoclonal antibodies. But we have to note that this is mainly for the cutaneous dermatomyositis, not limited to anti-synthetase. But the most promising result is shown here. EGYSIR improve the very nice results when assessing the cutaneous dermatomyositis disease area and the severity index activity. And indeed, in the scheme, histology, they shows the improvement of the interface dermatitis, which is a very typical form of dermatomyositis histology patterns. Next, as a B-cell targeted therapy, rituximab is also recommended, especially for anti-synthetase syndrome. This is very old clinical trial, but compared to other subphenotypes of myositis, this is anti-Jo1 antibodies of myositis damage index-free survival. And especially patients with Jo1 antibodies show the preferential improvement and damage-free survival as shown here. So the rituximab can be a good option for treating the patient with anti-synthetase. And efgartigimod, which is also newly developed biologics. And this target the B cell. So usually the IgG is endocytosed by endothelial and antigen-presenting cells. And IgG, if the IgG does not bind to FcRn, this can result in the lysosomes degradation. But when we administer the efgartigimod, this can bind to the FcRn, and this leads to the lysosome degradation. So we can suppress the antibody recycle. So this is the results of the Archivia study, and this is a phase 2 trial, the very promising results. With the FcRn blockade, the total improvement score at 24 weeks is significantly higher in a efgartigimod group, and this is very reasonable when considering the disease pathogenesis. And lastly, I'd like to just briefly touch the CD19 CAR-T cell therapy. So again, we just run how this therapy can work. But again, if the autoreactive B cell exists, this can be the exacerbation of the disease. However, the CD19 CAR-T cell was administered. This leads to the apoptosis of autoreactive B cell. And there are just three case reports treating the anti-synthetase patients with the CAR-T cell therapy. 41-year-old man who have the Jo1 antibody. A very refractory case is shown here. However, once the patient was administered CD19 targeting CAR-T cell therapy, the CK became within the normal range, and also Jo1 antibodies is decreased. And authors insisted that the drug-free remissions was observed after the administration of therapy at 6 months. And this is also the 41-year-old man case, but this is a different case. This patient also very refractory, had a refractory myositis and interstitial lung disease. But again, this case also demonstrates that the anti-Jo1 drop and maintain the remission with the mycophenolate monotherapy at 8 months. And another case is this is a very impressive case. But this is the report from Erlangen. 44-year-old woman who have refractory antisynthetase failed to rituximab and ocrelizumab. This is anti-CD20 biologics. So first, and this patient, after administration of CAR T therapy, this patient achieved complete drug remission for 9 months. However, after the first CAR T administration, the CK level is elevated after the 10 months, and MMT8 score is decreased. And yeah, and even though the patient had the second CAR T CD90 CAR T cell therapy, CK level was not decreased, and MMT level remains low. So then, as we learned just before, this after the administration of BCMA, B-cell maturation antigen CAR T cell therapy, the MMT score improved as shown here, and the anti-Jo1 antibodies was also decreased. Again, so CD138 is a surface marker of plasma cell, which is the main source of all the antibodies. So this is very reasonable because the CD20 expression was observed in B cell and some parts of plasma cell, but when we deplete the CD130 plasma cell using the BCMA, we can see the depletion of plasma cell. This can be more powerful for treating the patients with a refractory antisynthetase. And the monocyte and macrophages, I didn't mention that deeply, but also important. So we need the new treatment strategy targeting the macrophages as well, because the macrophages is also important pathogenic cells especially in terms of the interstitial lung disease. So in summary, we have to recognize antisynthetase as a spectrum. So we can observe the patients who have a very typical case, but we also see the very heterogeneous types of patients. And all the antibodies such as Jo1, PL7, PL12, OJ, EJ can be can be helpful to predict the disease phenotype, but does not capture all endotypes. In addition to that, we should more focus on the disease clinical phenotypes, such as rapidly progressive interstitial lung disease and dermatomyositis like skin rash and typical antisynthetase case. And this may help predict the disease prognosis. And also, we are developing the new classification criteria, more driven by the data, large-scale data. But this is not perfect at the moment. So instead of that, we need to consider the disease pathogenesis and targeting each abnormal cells. And for like the targeting T cell, interferon, B cell, or plasma cell. And I think that in the future, I think we should more focus on the pathogenesis and consider the treatment strategies. Thank you for the attention.
Thank you very much, Dr. Izuka. Any questions? Yes, Professor Dalia Faiz. Will you introduce yourself to Dr.
Thank you for your informative lectures. I want to ask you about how to diagnose rapid progressive interstitial lung disease as early as possible, and would you advise to start with cyclophosphamide with or without antifibrotic medication? Thank you.
Oh, thank you for the important question. So at the moment, of course, we have the definition of the rapidly progressive interstitial lung disease, but generally we more rely on the clinical cause. So patients, also when we diagnose the patient with antisynthetase, we should perform the HRCT as fast as we can, and also we should carefully follow the symptoms such as dyspnea and dry cough, etc. So, and this is one of the clues to capture the symptoms and rapidly progressive pattern or not immediately. And what was the second question? Antifibrotic agents. So we don't have the sufficient data to initiate the antifibrotic as early as I can is good for the better prognosis or not. But I think when the patients have the aggressive disease, I mean in early phase, this is the phase of the inflammation, not fibrotic. So at that stage, we should focus on the anti-inflammatory treatment, such as cyclophosphamide, glucocorticoid, and other immunosuppressants, such as carcinoid inhibitors. And I think we also should care about the cost of the treatment. Currently, the antifibrotic agent is very expensive, so it can be beneficial for the alleviating the fibrosis when we administer it at early phase. But I think it doesn't necessarily in the early phase. Thank you.
Dr. Wala Elbaz, Professor Immunology and Rheumatic Disease in Azhar University. Can I ask you, what is the difference? Is there any difference, clinical or radiological, between the pulmonary affection for antisynthetase than the other forms of immune-mediated inflammatory myositis?
Thank you. So as mentioned, this HRCT pattern is very crucial for diagnosing the antisynthetase syndrome. Patients who have the NSIP pattern and OP pattern is very useful to diagnose the patient with antisynthetase. And if the patient who have such ILD pattern with the positivity for antisynthetase antibodies, we can relatively easy to diagnose this patient. But as you said, it is important to exclude infection and other differential diagnosis. So this is very basic, but we need to take the sputum samples to exclude the other respiratory infections, and but I think generally the patient do not have the phlegm, so yeah, I think it's not the case. It's not so. There's no. Yeah, I think the CT pattern is important for diagnosis.
Thank you very much, Dr. Izuka. I think we're just one short question from.
Thanks, Doctor, for interesting and concise the lecture. Mahmoud Ghanima, lecturer of internal medicine, rheumatology, Cairo University. I'd like to ask about your opinion about use of JAK inhibitor. We mostly in myositis screening for malignancy for many years after diagnosis. So what about JAK inhibitor that also increase risk of malignancy? Thanks.
Thank you very much. Yeah, so as you know, in RA, we have to check the risk of the malignancy when we prescribe the JAK inhibitors. But I think when we prescribe JAK inhibitors to the patient with myositis, should be limited in a case of the very severe cases. So we have to screen the malignancy risk. But in the limited cases which really requires JAK inhibitors, we should prescribe the JAK inhibitors.
Thank you very much, Dr. Izuka. I'm looking forward to meet again in future lectures and presentations. We appreciate your generous offer to join our meeting. And by Dr. Izuka's presentation, we come to the end of the part 1 of the review course.